Shalom, and thank you for inviting me. It's really an honor to be back in Haifa and to have a chance to talk to all about you about a topic of mutual interest, understanding why is it that older people become disabled after hospitalization. So before, I'm going to just take 2 or 3 minutes to tell you a little bit about where I come from and the people I work with, because I always like to advertise our group and talk about some of the great people in our own group. So where I come from is actually about 8,000 miles away, but topographically looks very much like Haifa. As a matter of fact, San Francisco is often called the city on the bay, just like Haifa. So this is a picture of our most famous landmark, the Golden Gate Bridge. So Dr. Zisberg was remarking to me yesterday that she'd been in San Francisco several times and actually never saw the bridge because it was always shrouded in fog. And that's actually true, that it actually never looks like the pictures you see in the book. San Francisco is always foggy and you often can't see that bridge. So I come from a place called the University of California, San Francisco, which we call UCSF. So it's one of 10 campuses of the University of California system. UCSF is a health sciences campus, and it has a medical school, a nursing school, a pharmacy school, and a graduate school. I'm within the geriatrics division within the medical school, and our group works to improve the health and healthcare and clinical care of older people. And we have about 30 faculty, and we focus on clinical innovation, education, and research. And we all have our missions that work together, and my focus has been on research. And this is a group of our faculty. Now, this actually is what San Francisco usually looks like. The bridge is right behind us, but you can't see it because it's a typical San Francisco foggy day. And later on, I'm going to flash this away in about 30 seconds. If any of you can identify me on this, you get extra bonus points. So I'm going to just tell you, just to have a sense of the sort of stuff that our group does, I'm going to just show you faces of 3 of our star faculty at UCSF. So Jeannie Kaiser-Jones is in the School of Nursing, recently retired, but was a very important collaborator of ours, and I think is probably the best known gerontologist, probably not just in the School of Nursing, but throughout our university. So Jeannie was a medical anthropologist, and she did really interesting work in nursing homes trying to understand quality of care and why is it that in spite of all the costs of nursing home care, patients still feel that their dignity is not respected. This is Louise Walter, who used to be my mentee and is now my boss and division chief. So be nice to people you mentor because they could one day become your boss. So Louise has done really interesting work on cancer screening. So a big interest in our group. So we have a big problem in the US in that we spend lots and lots of money, I think about twice as much money on healthcare as Israel, but we actually have a lower life expectancy than Israel. So Louise has been really doing landmark work in how we overtreat older people, and her paradigm has been cancer screening and how we do cancer screening in older people even when it's harmful. And the last picture I'm going to show you is particularly important because this is Mike Steinman, a very important friend and colleague of mine at UCSF, who studies drug prescribing in older people and comorbidity, what happens when older people have multiple diseases at once. But why Mike should be really important to you is Mike's going to be hosted by Dr. Shadmi, and he's going to be doing a sabbatical in Haifa for 1 year starting in July. So don't tell Mike I told you this. His email is mike.steinman@ucsf.edu. So Mike is both brilliant and incredibly nice, and anyone who has a research problem, whether it's in his area or not, you should talk to him, because anytime you talk to Mike about a research problem, you will get new perspectives. So take advantage of Mike being here next year and talk to him often. Okay, I have stalled long enough, so on to the topic of the day. So we're going to talk about 5 areas in the next 35 minutes or so. First, we're going to define hospital-associated disability. We're going to talk a little bit about how often it happens, and then we're going to talk about the risk factors, both which patients are at highest risk for this problem, but also what hospital processes seem to cause this problem. We'll talk a little bit about how it can be prevented, and then we'll talk about the role of palliative care when it can't be prevented. So to get us started, I'm going to present 2 cases, but these 2 cases are actually the exact same patient. But the first time I present the case, I will be starring in a role as the patient's doctor or nurse, and the second time I present, I will be in the role of the patient's daughter. So let's think about why these 2 perspectives differ and who has it right. So clue is, when you present a clinician and a patient perspective, it's usually the patient that's right. So here's the first case presentation, maybe presented the way one of our residents at UCSF would present this. So Mrs. Goldstein is an 80-year-old woman who was hospitalized with cough, shortness of breath, and fever. And after she came to the ER, her x-ray showed pneumonia. So we treated her intravenously with antibiotics for her pneumonia. Like a lot of older people with pneumonia, she was dehydrated when she came in, so we also put in an IV for fluids, and we wanted to make sure we were monitoring how much volume and fluids we were giving her, so we put a catheter in her bladder to make sure we watched that really closely. So 6 days later, she was just doing great. Her labs were normal, her chest x-ray was getting better, her oxygen in her blood looked normal, so we sent her home. So this was yet another successful hospitalization at the University of California, San Francisco. So now let's hear what the daughter has to say. So Mom was getting a little bit frail at home, and I checked in on her once a week, but she was doing okay with, as long as I checked on her once a week, she was living quite independently and was, quite spry. Then she got sick, and we brought her to an emergency room, and they all said she had pneumonia. So they put her in the hospital, and when she was in, they attached lots of stuff to her. There was like an IV here, they put these monitors here, they put this catheter in her bladder, which she just really hated. And she was in this room and it was all noisy and things were beeping on and off. And when she was in the hospital, she stayed in bed all the time, and she was quiet and confused, which wasn't like her because Mom always had an opinion about everything. Then one day they called me and they said she was ready to go home. So I got to the hospital, and they took out the catheter in her bladder and they took out all the tubes that day. And she didn't really look ready to go home, but I didn't really feel like saying anything I was too nervous to say anything to the doctors and nurses. So once she got home, she just needed a lot of help. I had to actually see her every day instead of once a week. And she was falling a lot, and I needed to watch her take baths and showers. She sometimes would fall getting out of bed. So 1 year later, she had to enter a nursing home, and she passed away 2 years later. So the doctor's summary here is that it's a successful hospitalization because her pneumonia, that's why she was in the hospital, was cured. The daughter's summary is that everything seemed to fall apart for Mom after she was hospitalized, and it was the start of this downward spiral. So the question is really, who is right? What happened, and is what happened in this case common? So the short answer is yes, it's very common. And what the daughter is describing is the way patients and families often experience hospital-acquired disability. So this is the process in which hospitalization often precipitates disability in older persons. So after discharge, an older person or elder is no longer able to take care of themselves without assistance. So the definition we tend to use in research studies, and similar to the definition that the really esteemed group here uses, is to compare function at the time of discharge to function before the patient got sick. So we define hospital-associated disability as an older person who needs more help with activities of daily living before they became ill. So this means they need help in bathing, dressing, transferring, toileting, or eating. Now, what's important about this is that it's generally after hospitalization for a medical condition that's not disabling. So when people think of disability, they often think of stroke or hip fracture, but it actually often is pneumonia or an exacerbation of congestive heart failure. It happens after what we typically call successful medical treatment. And in fact, if you call successful medical treatment treating the condition for which the patient came in the hospital, it is successful because it's usually better. So now let's look at how often this happens. So the short answer, as I said, is it happens a lot. Prospective studies of hospitalization show that 1/3 of patients over the age of 70 will leave the hospital with a major new disability they have that they did not have before they get sick. When you're looking at patients over the age of 85, that's 50%, 1 in 2. So it's more likely than not that somebody over the age of 85 is going to leave with a major new disability. So I'm going to present you some data in the next few slides that put some numbers on these problems. So this comes from a study we did, oh good grief, it's been 11 years, that's too long. This used to seem recent. So this was the study we did in 2003. And let's see if this works here. So basically, simple study design, and very similar to the study that's being done here. At the time patients were admitted to the hospital, we asked them about whether they needed help in activities of daily living. We asked them whether they needed help before they got sick, and then we looked at whether they needed help at discharge. So the bottom line from the study is at the time of discharge, 35% of patients over the age of 70 need help that they didn't need before they got sick. So 35% of patients have hospital-acquired disability. What's interesting about this is we weren't the first group to do a study like this. There were several studies done like this in the decades before us. There have been studies done in the decade after us, including work here, studies all over the world. This figure of about 35%, it's been remarkably persistent over 3 or 4 decades, and it's remarkably persistent all over the world. So this seems to be a very generalizable, long-standing phenomenon. So the next series of slides is going to just dissect this. And don't worry about the exact numbers I'm going to show you. The point is really to kind of get a sense of how dynamic functioning is in patients who are admitted to the hospital. So the first question is, what's happening between the time the patient, before the patient even gets to the hospital, between the time they get sick and they're admitted? So it's roughly half and half. So basically, at the time the patient comes to the hospital, 43% are admitted with a new disability, and 57% have not been disabled at the time of admission. So let's look what happens to each of these two groups during the hospitalization. So what happens to the group that had functional decline at the time of their admission? So remember, the illness is getting treated. The medical problem's getting better. So what about the disability? Is that getting better? Well, the answer is, even though the medical illness is getting better, the disability is not. So of these 43, 20% recover, less than half. 18% don't recover, and 5% actually continue to get worse, even as they're being treated. So what about that group that was stable at admission? So surely a patient who came to the hospital without a new disability deficit, they should be out of the woods and they should do fine during the admission. But in fact, of that 57%, 12 of that 57 actually get decline in the hospital. So even though the medical problem's getting better, the disability is getting worse. So this slide puts it all together. I train a lot of research fellows, and this is an example of the type of slide I tell them never to present at a meeting because it's too complicated, it has arrows flying all over the place. But that's the point here actually, is that disability is complex, and the point of all these arrows is to sort of understand that when patients get sick and they enter the hospital, function is going all over the place. So even though this is not a common clinical measure that we actually measure clinically when patients are in the hospital, it's almost like a vital sign because it's changing so much. To advertise one of your own colleagues, Oleg sitting right over here, there's a really interesting study that he just published with his colleague sitting next to him that was just published in the Journals of Gerontology. So what Oleg showed is if you take these 5 groups, actually knowing how function is changing and which trajectory somebody on is very prognostically useful. So each of these groups has a very important prognostic implication. So that, it really matters if you go into the hospital disabled. It has huge implications for long-term function if you get better or if you don't get better. So in terms of the dynamics of hospital disability, disability is changing rapidly over the course of acute illness. And at discharge, the disability that you see at discharge is a combination of the failure to recover pre-illness function during the hospitalization, but also new disability that's happening during the hospitalization. So an implication of this is that reducing disability requires both rehabilitation of the disability or the decline that happened before the hospitalization, but also we need to prevent new decline that's happening during the hospitalization. So actually, when I first got into this work, I was, sometimes wondered if we overrated this problem because I was sort of thinking, well, okay, of course sick people maybe have some functional deficits when they get sick, but then when they go home, surely it gets better. So a friend of mine at Hopkins, Cynthia Boyd, actually pointed out to me that we had the data to address whether this was happening, but we just had to bother to look at it. So Cynthia did this really great study where she looked at the one-year outcomes of patients who are discharged with hospital disability. And they're like strikingly awful. I mean, so hospital disability is really as bad as hip fracture in terms of outcomes. So one-year outcomes for patients who are discharged with functional decline show that 30% recover, so less than 1 in 3 at 1 year will be no longer disabled. 28% are alive, but they haven't recovered, they're still disabled, and 42% have died. So in the US, almost prognostically bad enough to get one into hospice. It turns out that 1 month recovery is a really big predictor of what happens at 1 year. So it seems what happens in that first month is really important. So if you recover by 1 month, there's a 56% chance you will still be recovered at 1 year. But if you don't recover by 1 month, there's only a 17% chance, 1 in 6, that you'll return to your baseline level of function at 1 year. So this seems bad, but let's think about who's at risk. So let's look at some patient factors that put one at risk, and let's look at some hospital processes that put one at risk. So before I talk about some specific patient risk factors, let's think just for a second about what is going on with disability. So this could be an hour lecture in itself. But here's some basics about, theories of the disabling process in older people. So when a young person gets disabled, it's often like an automobile accident or some sort of trauma. It's often sudden, boom, somebody's was well and now they're disabled. And older people, it's this very slow, gradual, insidious process. It happens over a long period of time. And it's this slow progression of functional impairments. So when I was in medical school, I was often taught to think in terms of a differential diagnosis. So a patient had a problem, and I was supposed to identify the cause. So this is part of the problem with how we treat older people, actually, because in older people, there's not a single cause. What's going on is actually, it's this accumulation of stuff, this accumulation of vulnerabilities. You could almost call this frailty. So it's the impact of disease, things like diabetes and heart failure, so that all come together to cause problems. It's often things like developing cognitive impairment, and social and psychological factors like depression all play a role. So all these patient factors and deficits conspire and add up to cause problems. And then you have this frail, vulnerable patient who may not be disabled, but they're at risk. And then a precipitating event, something happens, and a precipitating event can be really minor, like that hospitalization for pneumonia. It pushes them over the edge into frank disability. So basically, the way to think about this is you have a frail older patient, and a minor hospitalization is a precipitating event. It's the most common precipitating event for disability in older people, and it brings them to disability. So when we say hospitalization is a precipitating event, the obvious thing to think of is the acute illness, whatever brought them into the hospital. But what's important to think about, actually, we're learning the precipitating event is not just their illness, it's what we do to them, that there's processes that happen in the hospital that increase the risk for disability. So as you would guess, the biggest risk factor for disability is increasing age. So this is a study we did, and it was actually part of the same study I presented earlier, where we looked at the risk of hospital-acquired disability as a function of age. So it starts at 23% risk of hospital-acquired disability in those who are 70 to 74, going all the way up to a very high rate of 63% in patients who are over the age of 90. But it's not just age. So a maxim in geriatrics is that if you see one 80-year-old, you've seen one 80-year-old. So it's not just age, but it's the problems that an older person brings with them. So some risk factors for hospital-acquired disability include depression. So for example, high depression scores increase the risk of disability about 2.5-fold. Cognitive impairment, so for example, delirium increases the risk 3-fold, or failed cognitive screens, things like dementia increases the risk 4-fold. Patients who come into the hospital with mobility problems, for example, needing a walker or having balance problems, have about a 3-fold increased risk. And then there's social factors. So actually, social factors are as important determinants of outcomes in geriatrics as medical factors. So limited social support and poverty are also important risk factors for disability. So the patient brings risk factors, but what about the hospital? So there's a number of things that happen in the hospital that really seem to increase the risk of hospital-acquired disability. So this includes limitations in mobility that are often imposed upon patients, things that we do to cause delirium, and also the progression of malnutrition during the hospital. So I'll speak a little about each of these. So this is one of my favorite studies done by a colleague of mine, Cynthia Brown, at the University of Alabama. So she did this interesting study so VA actually doesn't stand for Virginia, it's Veterans Affairs. It's the Birmingham Veterans Hospital. And she did this study where she basically attached these accelerometers to patients who were in the hospital. So what was interesting about the patients she chose for this study is she tried to choose people who were ambulatory at the time they were hospitalized. So all could walk before the hospitalization. and 80% of them could walk unassisted at the time of admission. So these were patients who, if you gave them a chance to walk during the hospital, probably could. So how do these patients spend an average 24-hour day? So 83% of their day, 20 hours, is just flat, basically lying flat in bed, not even sitting up, but just flat in bed. 13% of the day, or 3 hours, is sitting, and only 4% of the day is standing or walking, just 55 minutes. So patients are put to bed in the hospital, and then they stay there. So here's a great study that came out of your own institution by Dr. Zisberg and Dr. Shadmi. So they asked the question of, well, does it matter how active patients are in the hospital? So these were 525 Israeli medical patients, probably mostly Haifa patients, right? So this is done here. So I'll let Anna stop me if I'm describing any of this wrong. But she classified patients into 3 mobility groups. So the high mobility group were patients who got out of their hospital room. So this is not like the Jerusalem Marathon. This is like just getting out of the hospital room. The intermediate mobility group stayed in a room, but they at least got up and walked in a room. And the low mobility group wasn't walking. They were either in bed all day, or maybe they got out of bed and transferred once or twice a day. So in this group, if you were high mobility, only 13% were disabled when they were discharged. Intermediate mobility, 35% were disabled at discharge, and low mobility, 71%. So that's like a huge difference, 13% versus 71%, depending on mobility in the hospital. So what's going on here? Like, why do patients stay in bed? Well, to be honest, part of this was training. So like when I was a resident, I was trained, for example, that if you had a patient with congestive heart failure, the first thing you had to do was bed rest. And I don't know why we were taught that, but we were. So that, like, I actually would write that. I was like, this is before I learned any geriatrics. As a resident, I was one of the people who was causing hospital disability. I would write, admit, diagnosis, congestive heart failure, activity, bed rest. So some of it is stuff we do. We've learned a little bit more. We don't write bed rest orders anymore, but we do things that essentially keep patients in bed. So we attach IV poles that make it impossible for patients to move. Simple things like oxygen, which, once you start a patient on oxygen, you never take it off, even if they don't need it anymore. So oxygen kind of becomes almost a restraint. The EKG or monitoring leads that in our hospital, all the residents put all the patients on monitoring because they feel safer, even though they don't know why they're actually doing the monitoring. And urinary catheters. So a colleague of mine, Sanjay Saint, who's now at the University of Michigan, called the urinary catheter a one-point restraint. Being the Bay Area, we've gotten really sophisticated with restraints. So I have to add a new one to this list. So do you guys use bed alarms in Israel? So now, because in the U.S., hospitals get penalized by Medicare if their fall rates are too high. So basically, the solution in a lot of U.S. hospitals to prevent falls is to just not let patients move. So now a lot of hospital beds have alarms. So like whenever a patient tries to get up, there's this big buzzer that basically alerts the patient to stay in bed. So now instead of having patients fall in the hospital, we get them really weak so they can fall at home. We're cynical in the U.S. Now, another thing that we seem to do in the hospital that causes disability are things that induce delirium. So what is delirium? So delirium is extraordinarily common. It happens to over a third of older people in the hospital. It's an acute confusional state characterized by inattention, disorganized thinking, waxing and waning consciousness, and sleep-wake disruption. So I'm reading this sounds a lot like jet lag. But this actually happens in the hospital all the time. So interestingly, though, this really terrible phenomenon, there's studies that show that when it happens to patients, doctors and nurses only recognize it about 1/3 of the time. So there's two types of delirium. There's the hyperactive, which is basically patients are agitated, they're pulling out their IVs, and they're really, they're angry and they're yelling, and that's maybe about 1/3 of delirium. But the more common delirium that almost always goes unrecognized, unless you really are trained to look for it, is the hypoactive form. So the more typical picture of delirium is the really quiet patient sitting in bed who doesn't talk much, and you don't spend much time with, because when you ask her questions, she doesn't really answer because she can't really follow your thinking, and her answers don't really make much sense. So delirium is really bad. It dramatically increases the disability risk, and it lasts a long time. We used to teach that delirium was transient, but we now sort of know that it's not, that once it happens, if you have a patient in the hospital with delirium, they're probably going to go home with cognitive problems, and probably a good number of those are going to be at increased risk for dementia. So when you look at what causes delirium, it actually looks very similar to the list of hospital-acquired disability. It's a very similar underlying process. So it also includes low mobility, sleep disruption, so the kinds of things we do in the hospital, vital signs, waking patients up for vital signs. Hospitals are really noisy with beepers and phones going off. Patients sleep during the day. Sensory deprivation is a really important predictor of delirium. So patients who have vision or hearing impairment go in the hospital. In the US, patients almost never have their hearing aids or their glasses when they go to the hospital. There's a direct correlation between starting new medicines, especially psychoactive medicines, especially medicines for sleep, that seem to induce delirium, and also dehydration, so inadequate fluid intake. So the third hospital process I'm going to describe is malnutrition. So when patients are in the hospital, weight loss is common and muscle loss is very common. And so albumin's a measure of body protein stores, and when a patient's in the hospital, albumin drops by an average about 0.5 point. So that's huge. That's a big drop. So what do we do to cause this? We often in the hospital have needless NPO orders, which means nothing by mouth. We don't let patients eat. We don't assist patients with eating. So sometimes when I would round on weekends, I'd come in and you'd see the trays by the bed completely unopened, and it's because no one's helping patients open these little containers that actually take a lot of hand coordination to open. And we often give overly restrictive diet orders. So we put patients on these diets that no one in their right mind would ever eat, these really low sodium diets, the so-called diabetic diet. So when I talk to our residents, I try to remind them that hospitals are not prisons. So that if you give a patient a diet order and they don't like the diet, they actually get to choose not to follow your diet order. So patients will probably do better with just letting them eat whatever they want. So here's another study, almost hot off the presses. This was I think this was January, right, in JAGS. So just published this year from the Zisberg team. And really interesting confirmation that, this is not just geriatric theory that these vulnerabilities in hospital processes act together. So this was another 684 Israeli inpatients. And Anna looked at patient risk factors in hospital processes. And the hospital processes in her study that were most important were mobility, and also an area that actually has not been as much studied, continence care. So things we do in the hospital that probably induce incontinence. And this together explained about 64% of ADL disability at discharge. So what was particularly interesting is that these data showed that mobility and continence care were very important implicants or very important precipitants of the disability cascade. So they seemed to lead to disability at discharge, and they led to disability that seemed to then persist after discharge. So we've talked about some of the bad things we do in the hospital. So can we do anything about this? Is disability always inevitable? Well, maybe if people live long enough, or patients live long enough, maybe somewhat, but we certainly can delay it, and we certainly can make it less frequent. So I'm going to talk a little bit. There's been a number of different types of approaches to reduce disability. Today I'm going to really just focus on just one, something called the Acute Care for Elders Unit, because I saw on your schedule that I think some of the other methods are going to be discussed further on today. So what's an acute care for elder unit? Acute care for elders, that stands for ACE. So ACE is a redesigned system of hospital care. So the goal of ACE is to reduce the rate of functional decline in the elderly. And the concept of ACE is really, it's based on sociological concepts of person, environment, fit. So the concept of ACE is to really change the hospital to fit the hospital to the older person rather than the other way around. So ACE units include environmental redesign and process redesign. So we'll talk a little bit about both. So in terms of environmental redesign, ACE units include geographically delineated units that encourage mobility, things like carpeted floors and lighting that make it easier to walk, common eating areas to encourage socialization and walking, quiet environments to try to reduce the risk of delirium and improve sleep, so things like soft phones, vibrating beepers, closed doors. Orientation clues like large calendars and clocks. Sensory aids, again, to help prevent delirium, so vision and hearing assistive devices. And also families are encouraged to stay overnight. So a key part of the ACE unit is an interdisciplinary team. So really any good geriatric or old person intervention is based on different disciplines in healthcare working together as a team, rather than each discipline doing its own thing. So ACE units include assessments by nursing, medicine, social work, pharmacy, and physical therapy. And the team works together to formulate daily plans, grounded in a knowledge that a single discipline intervention does not improve outcomes. So ACE units, we heard earlier about how important mobility is, and ACE units have a lot of processes to enhance mobility. So nurses are helped to encourage mobility. There's easy access to bedside chairs, so at least the concept in an ACE unit is that you're only in bed when you're asleep. There's standing orders for the patient to be out of bed. And then there's limited placement of bladder catheters and other tethers. So instead of having like a catheter or an IV and the whole hospitalization, there's much more of an effort to really review that every day and see if those can come out earlier in the hospital stay. So I'm going to grab some water here. And so ACE units also, a big part of ACE units also include functional protocols, so protocols to prevent functional decline. So ACE units encourage daily assessment of functioning. So for example, assessment of ADLs and mobility. They encourage independence, so for example, dressing in street clothes, independent bathing, raised toilet seats, and also encouraging independent transfers. So another part of ACE units is really careful review of medicines, because as we mentioned, medicines are an important part of inducing delirium. So a lot of ACE units will have a pharmacist round with a team. There will be daily review of medicines, and there's really attempts to minimize drugs that are associated with delirium. So much more focus, for example, on sleep and in terms of behavioral problems, of really more behaviorally based approaches. So there's this really interesting protocol developed by Sharon Inouye for sleep to try to prevent the use of sleeping pills. So this is very low tech. Quiet rooms, avoiding nighttime vital signs, back massage, and warm milk. So almost wants you to go into the hospital. So ACE units also include a big process on thinking about planning to go home. So this is different from the traditional discharge planning. So it's motivated not by bed utilization, which is a big focus on in the US, but really grounded in functional assessment. So it starts on admission, and it's a continuous process, and really focused on patient and caregiver needs. So an explicit focus on what the patient needs to get at home safely. So what happens with ACE units? So there was this meta-analysis that was published about 5 years ago that looked at 5 studies of ACE units. And what it showed is that there's a 30% increased chance that if your patient is on an ACE unit, that they will be able to go home instead of going to a nursing home. 18% reduced risk of disability at discharge. And other outcomes included decreased length of stay, lower risk of readmission, and increased patient and staff satisfaction. So we're almost done. So just a few words. We've talked about how ADL disability and hospital disability can be prevented. This is like my one thought about where the field needs to go in addition to this, because a lot of the work has focused on the prevention of disability, and we really need to focus on that. But we also need to focus on improving the quality of life of those who are going to leave the hospital disabled. So that's what I refer to as palliative care. Not the cure or prevention of disability, but also how do we palliate those who are going to become disabled. So we know that hospital disability is often preventable, but it's not preventable in all cases. And most who live to an advanced age are going to have a prolonged period of disability. So for example, if you live to the age of 90, on average, you're going to spend the 2 last years of your life in a state of disability. And it'll also happen in the setting of hospitalization. So we want to prevent it as long as we can. But if you are going to become disabled, we want you to live a high quality of life when you're disabled. So let's think about a little bit about what maybe the next version of an ACE unit would look like. What I call ACE2. So the ideal hospital unit will include a focus on quality of life and well-being. So the ideal hospital care for an older person will think about disability prevention and do all we can to prevent disability. But we'll also focus on palliation, not just hospice-type palliation, but palliation through the long process of chronic illness. So in a hospital unit, disability prevention is a central goal in some, if not most, patients. And palliation is a central goal in some, and maybe most patients as well, sometimes the same patients. So we know hospital disability is sometimes preventable, but it's sometimes part of serious illness. So we know disability will sometimes be preventable, but even when disability is not preventable, palliation and helping somebody with disability is always possible. So let's finish up. So if you've been getting tired, this next final slide has my 5 main points in 30 seconds. So if you just hear this slide, you'll hear my main points. So many older persons develop new disability during the hospitalization. Disability has a poor prognosis, and it's often permanent. Hospital processes often contribute to the development of disability. Better models of hospital care reduce the risk of disability, but not all disability is preventable, so we should be focusing on both the prevention of disability and palliation. So thank you very much, and many thanks again for inviting me.